بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين وعلى آله وصحبه وسلم. We are going to continue the series of approach to mammography, the second lecture based on breast embryology and physiology. Okay. Any volunteer to comment on this mammogram? Try to be quick. Suhair.
طيب. Okay.
Who stop Sarah? Okay.
Yes.
يلا.
طيب. This is the MLO view of a breast. It shows the area of asymmetry. Am I right?
Asymmetry or mass?
والله أنا شايفة كأنه في resembling ولا. Okay. Irregular mass at the right breast, centrally.
Where exactly? Where? You can describe by location.
Yes.
Where is the mass?
Yeah, at the center of the breast.
What do you mean by the center? Here? Here? You are talking about this?
Yeah, this.
This?
This, yeah.
You mean the right side? The
Yes,
pathology on the left. The pathology on the left, Sarah. Could you appreciate this?
Yes.
What is this?
There is a hyper. There is irregular mass seen at the axillary tail. Posteriorly.
It's okay. Axillary tail, well, just in it is projecting
outer.
In the pectoralis muscles. Okay. It's projecting in the pectoralis.
It is in the pectoralis, yeah.
Deep posterior, and even the posterior of the mass is not included, is not seen. And this, what is the structure? This is the pectoralis major. And what about this? The pectoralis minor. This is the pectoralis minor, and this is the pectoralis major. Okay. The mass is high density, irregular, speculated. Associated with what? No association. Compare the two sides. If you compare the two sides, same area, you could see what is going on. Look, this prepectoral or retromammary fat here, and you can see it here.
There's
infiltration?
Yes. What is that infiltration? What we call infiltration? The descriptors, yeah, I mean, the specific descriptors. What is that, Suhair?
Trabecular thickening.
Yes, representing what?
Edema.
Edema and architectural distortion. There is perilegion edema and architectural distortion extending throughout the outer, the outer breast. Okay?
Yes.
Because it's extending from the mass and the mass projecting into the pectoralis. That means just from the MLO, I could appreciate this mass is most likely, you see, in the upper outer breast. So, where the lesion exactly located? Or what is your differential diagnosis according to the findings? What could it be?
Could be lymph node.
It could be lymph node. Excellent. It could be a lymph node. This is in the axillary fossa. So it could be lymph node. What else? Could be lymph node.
Could be
From-
primary mass. Could be
It could be-
secondary.
It could be primary mass. Primary where? Due to what? In which area?
In the axilla, in the left axilla.
In the left axilla.
Axillary
Due
mass.
to what? Your differential, you are correct. Here you can see it more. You have dense speculated mass in the left axilla. It could be,
Could it
yes.
be
It could be metastatic lymph nodes. Where is the primary? If this is a metastatic. If it is metastasis, what yani, just the metastatic lymph
Could be
node like,
lymphoma.
huh?
Could be lymphoma.
It could be lymphoma. It's okay, huh? What else? Breast lymphoma, you mean?
يعني تكون part of lymphoma. lymphoma يعني تكون في lymphoma ودي
Common is
part of
common.
lymphoma.
So here, what is common?
Okay.
Start by common.
could it be a mass in accessory breast?
Excellent. Who said mass
Accessory-
in accessory breast?
Sarah.
Where is it?
Sarah, yes, you are right. It could be mass in accessory breast. Okay. What else? If it is not accessory breast, it is. If it is a mass, where it will be?
In a muscle mass. Muscle
No.
tube.
If it is the breast cancer, if it is a breast cancer,
Oh, okay.
this is in ectopic, breast cancer in ectopic, or arising from where? If you look here, you can see the pathology extending in the upper outer.
Yes.
What does it indicate? Okay, it could be mass in ectopic breast. It could be secondary metastatic lymph node from occult breast cancer.
Occult breast lesion.
It could be metastasis from extramammary malignancy, including lymphoma. It could be primary where? خلاص. Okay. We'll see it later.
Okay.
What about this one? Huh?
Bilateral accessory breast.
In the abdomen?
Projecting over the in the axilla.
Yeah.
Projecting over the
Say
axilla.
it completely. Say it completely, Suhair.
Okay.
This is bilateral MLO, okay, of ACR fatty breast
ACR.
and
ACR.
ACRA, and there are bilateral smooth semicircular masses projecting from the axilla having the same texture of a fatty of the normal or of the regular breast, which are fatty, consistent with bilateral axillary breast. Yes. And what is this?
Axillary breast.
This is axillary breast in a photo. And what are the presentation of the axillary breast? It can be just as a bulge like this.
Bump, yeah.
Or it can be a palpable abnormality, which might be associated with pain, or it can be just presenting by cyclic pain, okay, and so forth. And by the way, you see, though it is uncommon abnormality, but in our Sudanese nationality is very common. Is يعني no clinic, okay, devoid accessory breast at all. Every day we have seen 1 or 2 ladies having an accessory breast. It is very common. What is seen here? There is circumscribed mass, partially obscured, okay, projecting over the left axilla. It can be also accessory breast having
a mass.
A mass. And here, what you have seen?
Bilateral axillary breast.
Bilateral axillary breast. What is the difference between this and the previous?
The ACR here is ACR B, heterogeneously dense breast, and the same.
B or C?
I can see. C, it's okay.
C.
Okay.
C. So you said heterogeneous. Heterogeneous is C.
Dense C.
Yeah. And
both
slightly larger on the right side.
The right side.
So it is mostly following regular,
both breast ACR.
The first one, the breast was fatty. The normal breast or the regular breast is fatty. The accessory breast was fatty, but presenting as a bulge. Here, it is not presenting as a bulge. It is presenting as a fibroglandular tissue resembling the same fibroglandular tissue of the breast. Seen both sides, though, here it is a little bit more prominent, okay? And here, what you have seen here, this is the same case. And what about this? There is arrow pointing to the abnormality.
MLO of both breast at left side. The ACR of breast, then the ACR of breast are C also. There is an area.
There is accepted. B or C is accepted. It's okay.
There is an area of glandular, resembling glandular tissue of breast projecting over the right axilla.
Right axilla.
Slightly representing accessory breast of the right side.
Yeah, here it is bilateral, while here it is the other axilla is free. So here it is unilateral. So ectopic breast is a normal variant. Okay, we should not consider it as a pathology. It can be bilateral or unilateral. It can be small. It can be large. Okay, it is usually fibroglandular element density, okay, with sparse fat, similar in appearance or same appearance as the regular or the fibroglandular breast of the same breast. Okay, and the most important things to say this ectopic breast in the axilla is to locate it separately. To locate it separately from the main parenchyma of the regular breast. Why? And they found that the mean dimensions is about 4 centimeters in general. Measured in MLO or in exaggerated CCVO. Tell me why it's important to say this is an ectopic breast to be separate for the main parenchyma.
differentiated from the axillary tail or axillary tail of Spence?
Who said that?
Hint.
Oh, excellent hint. Excellent. That is why. That is why. You see, I went quickly here. Axillary tail, breast cancer. You see the difference between the axillary tail and ectopic breast is, continue hint. These are, yeah, these are the variations are important, very important. That is why. You see, to say this is ectopic, you have to see it separate from the remain of the parenchyma.
Yeah.
Okay. What about this case?
The first case, this one.
What about this patient?
Separate.
It is separate, but is it just an ectopic breast? Anything here?
Calcification?
Yes.
Microcalcification.
Calcification.
Yes,
So we have to
find
but magnification to characterize it further. So this is a breast cancer. Look, there is some distortion here and some skin thickening. There is a cancer presenting as calcification, suspicious calcification in ectopic breast. This is ectopic breast cancer, and they have propensity to develop malignancy and occur at earlier age. And again, this is an ectopic breast, okay, having this irregular mass seen on ultrasound due to a breast cancer. What about this?
رباب معلش سؤال.
تفضلي.
بس انت الحته بتاعت separate from the main breast قلت الامبورتنس بتاعتها شنو او هي ليه؟
Yes, we are going to talk about it.
Okay, تمام.
That is why I brought this example.
Okay.
Here is
Hint.
irregular.
What is difference?
This is
and the previous.
This is continuous. Yes, this is continuous
the
with
the parenchyma is continuous. So,
yes, and there is a high dense irregular mass.
Yes, projecting over the pectoralis
muscle.
Muscle. So this is expected to be
cancer, malignant.
Cancer where? Yes. Cancer in the ectopic or tail of Spence?
Tail of Spence.
Yes, this is tail of Spence parenchyma. Okay, cancer. Cancer in tail of Spence. Again, this mass found to be in tail of Spence. You see, if you look here, extending, there is a lesion extending so, yani, superior lateral. This is extended lateral view, and this is MLO, but still anterior to the pectoralis. It's not within the axilla. But this, it is in tail, though I could not see the parenchyma here, but it is at the tail of Spence. This is a liposarcoma, and these are cancers at tail of Spence. Okay? So, in contradictions to the accessory breast tissue in the axilla, which is supposed to be discontinuous with main parenchyma, the tail of Spence is continuous extension of the tissue of the breast that extend into the axilla. And this is important. How you can define the tail of Spence, hint, or any of you, if you know. This is the anatomy here. You can see this is the parenchyma, our upper outer parenchyma extending into the axilla, extending into the axilla. Through what?
Tail of Spence.
But this is the tail of Spence.
Yes.
Can you see here? Here, not very
Yeah.
clear. Look for the tail of Spence here. Is
Through the
extending
pectoralis muscle?
through. There is opening in the pectoralis fascia. You see, the pectoralis fascia, the Spence of tail is prolongation of the upper outer quadrant breast tissue, into the axillary direction. It is called axillary tail of Spence. It passes through foramen of Langer, you see, into the axilla. The axilla separated by pectoralis fascia. This pectoralis fascia, there is a defect in the pectoralis fascia called the foramen of Langer. When the breast tissue extending through this foramen into the axilla, they call it tail of Spence or axillary tail of Spence. And usually, if you remember him, while we are scanning also here, if you attend with me, usually I told you while you are scanning on ultrasound, don't raise your probe. Extend in the upper outer quadrant until reaching the axilla, because you are following. And if you find interruptedly there is no any tissue and you find something within the axilla, most likely it will be just an ectopic breast. If you have seen the breast extending up, then it will be axillary tail of Spence. And the management of cancer in the axillary area or axillary fossa depend on the etiology of the tumor. If it is occult breast cancer with metastatic lymph node, and if the first case was a metastasis, you have to comment on something. What is that? Something significant. If it is a lymph node, expected to have what?
Skin infiltration.
Extracapsular extension, because you have seen a lot of invasions in the adjacent tissue. It is not just a contact or lymph node, metastatic lymph node. If it is a lymph node, and very unlikely lymph node to have speculated margins like this, it simulates the primary cancer more than to be a metastasis. Okay, but if it is a metastatic and it is irregular and there is surrounding edema and architectural distortion, it reflects or it denotes that the lymph node have a capsular break and extracapsular extension of the cancer. Or it is an ectopic breast cancer, or it is an axillary tail breast cancer, or metastatic adenopathy originating from non-breast tissue. These are the differential diagnoses, and it is important to explain which is which. And preoperative evaluation, imaging evaluation is important, and definitely histologic evaluation can aid in the diagnosis. But sometimes, it is challenging, and radiology, pathology correlations can help. An axillary tail of Spence is a prime concern after prophylactic mastectomy. Why? Because residual tissue can be source for a recurrence. Okay. Another learning point is that the ectopic breast can exhibit the same spectrum of pathology of the regular breast, ranging from benign like fibroadenoma, mastitis, fibrocystic, even galactosele. We have a case before many months, you see, in Sudan. She has bilateral galactosele, pregnant lady, lactating lady. She has bilateral galactoseles in her axilla, you see, and 2 malignant lesions, including invasive cancer, medullary, and more rarely might show invasive lobular amyloidosis because of the component of the tissue. And the ectopic breast tissue has a propensity, higher propensity to develop malignancies than the regular breast. And even they found that it occurs at earlier age. So we have to expect if the patient she's a high risk and she has ectopic breast, we have to follow it in the same way as we screen her regular breast. And there is another issue, which is what is called macromastia or gigantomastia, or breast hypertrophy, or mammomegaly. Gigantomastia, breast hypertrophy, or mammomegaly. What is that? Is excessive enlargement of the breast, and usually seen with pregnancy or during puberty. Yani it is not something common, but phenomena can occur, which is something abnormal. It can be seen in the regular breast, or commonly seen in the regular breast, but it can happen even in the accessory breast. Sarah or Afra with us? Huh? They are not available.
Who?
Technologists. They are not with us. This is for them. Okay, but they are not available. Any of you can comment on this mammography? This is a CC view.
Yeah. Yes.
And this is
MLO.
MLO.
Yeah. هو scan is not covering
شكله
the
large.
whole breast.
لا
Large
large breast. عشان كده أخذت كم.
This is not only large. This is a huge breast.
Yes.
You see, for the MLO, examined in 3 images to cover the whole breast. This is mammomegaly. Okay.
Okay.
Or gigantomastia.
Gigantomastia.
Macromastia. Okay. And in some cases, it can be just excessive fat. With those who are, they have high body index, obese ladies, they might have it. But generally, it is seen with pregnancy, or seen in some cases peripubertal ladies. It can be, generally it is bilateral, but it can be unilateral. I have seen something like this, both the glandular one and the fatty one. You see, that is why I told you in the practice you'll be faced by these type of cases. And for me, after I have been faced, then I went and looked for the reason of this, and then I understand that I have to review the breast embryology and breast physiology to understand these issues. So this very common condition characterized by proliferations of breast fatty tissue or glandular tissue, or both, resulting in rapid increase in size over a rather short period. This is a gigantomastia. Okay, this is her right breast. Here, this is the left one, and look for the right one. For the, you see, even it is asymmetric. For the CC, 3 mg to cover the whole CC, and 3 mg to cover the whole MLO. See, and macromastia, they classified into 3 types. Type 1, they said it is idiopathic, related to the body mark, okay, overgrowth in female. If body index larger than 30, type 1A. If less, type 1B. And type 2, they said that is related to hormonal imbalance. related to pregnancy or puberty, and type 3 related to secondary to drugs. You see, they found that might be associated with hypercalcemia, hyperprolactinemia, or autoimmune disease like Hashimoto's, rheumatoid, myasthenia gravis, SLE, or psoriasis. So it is important to understand the breast development, which is a complex biological process known as mammogenesis. We are going to start it in 3 phases. We are going to start by the early prenatal development. Just in a simple way, during antenatal, there is a band of ectodermal thickening extending from the axilla to the groin bare of this band, seen both sides. You see, this band shortly after develop, it will regress. It will disappear, except for a small area projecting over the chest, forming the primary mammary bud. Okay, that is it.
معلش يا ضيف بعد اذنك.
اتفضلي.
بس الميكروفونات يا جماعه والكاميرات يا ريت بس تنتبهوا لها. الكاميرات في ناس كاميراتها مفتوحه if they are wishing انه يقفلوها، والمايكات بليز عشان التسجيل في شخشخه شديده في التسجيل.
Okay, can we continue?
مقفوله حسي كلها.
Okay, we said the embryogenesis of the breast during antenatal life, there is development of ectodermal thickening, band of ectodermal thickening, pairs of band of ectodermal thickening, starting from the axilla to the groin, bilateral. Shortly after they develop, it regresses. It disappears except for a small area projecting over the chest wall, which representing the primary mammary bud. Okay, this happens in embryo, girl and boy the same way. Okay, and here the ectodermal thickening. You see, this is the ectodermal thickening we have seen there. Start to invaginate into the mesoderm. And this is called the primary mammary bud or mammary or milk ridge. And this is hormonal independent. The hormones have no role in this formation of the primary mammary bud or mammary ridge. Then, still in antenatal lives and due to placental hormone, estrogen, progesterone, and prolactin, it stimulates the proliferation of both this ectodermal thickening as well as the underlying mesoderm. So the process happening in the ectodermal thickening, sending front-like bands, okay, into the invaginate into this mesoderm, which later canalized to form the duct, the lactiferous ducts. And at the coverage of this lactiferous duct, in the epidermal thickening here, causing a depression called epithelial bit. This is later going to develop the nipple areolar complex. Is it clear? While the underlying mesoderm later is going to form the stroma of the breast, fat, connective tissue, and vessels, blood and lymphatics. And both are hormonal related, are stimulating by the placental hormones. And the cancer cell, if we look here, you see, the ectoderm, look for the ducts, are formed from the ectoderm and are in continuation with the cells of the nipple areolar complex. And this can explain the theory of budget disease. You see, one theory of budget disease, that the cancer arising in the duct and extending from the duct into the cells of the nipple areolar complex. If we will go to understand this, it will be easy for us to understand the theory of a budget disease. Okay, so occasionally fragment of mammary, we said this one is the mammary bud or mammary line or mammary ridge. If incompletely involute, we said it has to be involute except for a small area in the chest, develop the breast later. If a small bit or a small area, it persists, it does not resolve or involute, it can develop another area of breast or a nipple, which is called polymastia or polythelia. What is polymastia? That means we have an ectopic breast tissue, which is seen from 1 to 6% inherited breast developmental abnormality. And polythelia, it is a little bit more here, it is a supernumerary nipple. And it is not always the whole breast is the residual part, or it persists, or it develops at this area of residual part of the milk line not resolved. If it is not resolved, it can proliferate into a breast tissue, either organized, complete breast tissue called supernumerary, or non-organized breast tissue called apparent breast tissue, or no breast tissue but only nipple, we call it polythelia or nipple. Can you see it here? How many? He has both sides, supernumerary breast, and here he has a supernumerary nipple, you see, and the axilla is the most frequently reported location for the ectopic breast, but rarely can be seen in the abdominal wall because you have seen the line going from the axilla to the groin. So there is a case report for a mass present in the abdominal wall, and they found to be just a mass in an ectopic breast tissue, and another case in the external genitalia also presenting with a mass. It is due to a mass arising in an ectopic breast tissue. And if the nipple present in a polymastia and it is the supernumerary breast tissue, it can secrete a milk like the regular breast. And as you have seen here, it can be seen in a male, because we said that there is no difference between male and female regarding the early development of the breast or rudimentary breast. And because it is pigmented, the nipple, it can be mistaken for a mole, a skin mole, if there is no breast tissue. And in the other hand, it might fail to develop the breast, either one side or both sides, and can result in amastia, no breast. Amastia, no breast, no nipple areolar complex, complete lack. It is a congenital characterized by complete absence of breast tissue, including nipple areolar complex. Can be unilateral or bilateral. Okay, and it's the same. Can be in female or male. And it can be associated with multiple congenital anomalies, like Boland's, can be associated with Boland's or by other congenital anomalies, multiple congenital anomalies. What is emasia? Emasia, there is lack of development of breast tissue, but the nipple areolar complex is normal and it's developed. As in this here, you can see just the nipple, but there is lack of breast tissue. You can see breast tissue here. You see on the right side, but in the left side, there is no breast tissue in a case associated with Boland syndrome. And also, as in the emasia or emastia, both of which can be associated with Boland's or by other congenital anomalies, and both can be iatrogenic. Emastia or emasia can be iatrogenic due to teratogenic exposure, due to injury early in life during development of the breast, due to radiations or surgery or whatever. And as you have seen here, definitely it can occur both in male and female. And here just we can revise this is the rudimentary, but you see, just the ectodermal thickening invaginating into the mesoderm, forming these rods or buds, you see, and here branching and start to form the mammary pit. Here the mammary pit will form, and this canalization of these rods forming the lactifrous ducts. All this process during antenatal before birth. So until when the baby born, both boy and girls, they have immature or primitive breasts, which remain unchanged until puberty. Though lobular, alveolar, and ductal system growth will be enhanced or influenced by estrogen, progesterone. It can be influenced, but are generally remain dormant as immature breast, similar in boy and girl until puberty. Okay. What is happening here? This is child girl and this is child boys having prominent breast tissue. Both of them having prominent breast tissue, baby girl and baby boys. But generally or usually, this happens a little bit larger in baby girls, which is a normal physiological process, can happen after 6 months up to 2 years. And then after it regresses and can be associated with follicular cyst. As you know, sometimes a child presenting with ovarian cyst found to be a follicular cyst, and these due to transient activation of hypothalamic pituitary gonadal axis. And this transient activation will quiescent by the age of 3 to 5 years of age. However, if it get progress, might be due to pathological process, and it can represent a precocious puberty, and this definitely need endocrinologist evaluations. And what is the clinical significance if it is unilateral? If it is bilateral, it will be straightforward. You see, it is obvious. This is something hormonal abnormality, and this is the breast. But when it will be unilateral, and especially if it is in a girl, but what is the problem or the clinical significance here? What?
I think it's a mass.
Yes, yes. and if they think it is a mass, if it is this misdiagnosed, so what will be the problem?
Surgery.
Baby girl, baby boy, no problem. But if baby girl, they
It
will
end with amasia.
Excellent, well done. So erroneous interpretations of breast enlargement as pathological can lead to amastic, girl child amastic. Okay, so the development, we said it is a complex. We finished the prenatal, and let us go to the pubertal stage. And as you know, at puberty, the female having the hypothalamic pituitary ovarian axis hormones, estrogen and progesterone having strong influence into lobular alveolar ductal system that result in proliferation of these structures, as well as in proliferation also of the stroma and fat, and enlargement of the nipple areolar complex, resulting in further development of the breast. This occurs in a female and called as, when the breast, rapid development of the breast during puberty, they call it what?
Premature cellular.
Is it a premature?
Premature cellular.
Why premature?
Mature.
Pubertal,
premature before 6 weeks. Yes.
No, this is a thelarch.
Yes.
What is a thelarch? Thelarch is rapid growth of the breast at the onset of puberty. You see, at the onset of the puberty, this is a thelarch. And as you know, it is due to influence of multiple endocrine as well as genetic controls or genetic factors. And when and what is the stage of Tanner's, corresponding to which stage of Tanner? Which stage?
3.
No, it is stage 2. Tanner is characterized by breast, but it is Tanner stage 2. At what age? What is the age at which there is a thelarch or is expected to have a thelarch, and the range of age before which you can say this is premature, and after which the girl needs to be investigated by endocrinologist. What is the time?
Premature.
Premature
before 6 years.
No. What is the time you expect to have the thelarch? At what time, if you have seen a girl, this is very common to come to ultrasound clinic. Here there is no role for mammography, but we have to follow just the sequences. This is generally in ultrasound clinic. You have seen it. We have other times we have seen lady bring her baby, okay, asking or why this child having this swelling, is it normal, is it abnormal, shall I go to endocrinologist, like that. A lot of times, very common. I don't know why, but nowadays it is really common things. So when you will reassure the mother, no, this is the large, and expecting, because it is usually Tanner stage 2, and it is usually asymmetric, and at certain age. No, be relaxed. this is starting of a cell arch, and this is the age expected to have this cell arch. No, still your child does not develop breast. No, you have to seek endocrinology advice, and you have to go and investigate your child. Or no, this is a premature cell arch, and just reassure you can follow since there is no other what? If there is no other secondary
feature.
Yes.
Feature of gyno.
أيوة. If there is no other features of what?
puberty
Gyno.
If there are other features, then it will be
premature puberty,
precocious puberty, and then she needs to be investigated by endocrinologist. So if it is before from 8 to 13, expected to have a cell arch. From 8 to 13. From 14, if the child does not, the girl does not develop breast, has to be investigated by endocrinologist. You see, if it is before 8, this is a premature cell arch. But from 8, expected to develop cell arch. And usually, before or after the pubic hair?
Before.
Yes, it precedes the pubic hair by about 6 months. Okay, and as we mentioned that it is due to stimulation of estrogen and pituitary growth hormone, and we said it is the first sexual characteristic between the age of 10 to this is generally between 10 to 12, but can be ranged from 8 to 13. After 14 has to be investigated. And as you have seen here, this is the rudimentary ductal system the child born with, you see? Until puberty, it will be like that. Baby girl and baby boys can be just stimulated by any transient increase in hormone, physiological or pathological. But it should be like that. During puberty, start to be stimulated due to female hormones. That is why in male, it will persist as rudimentary, except for if it is stimulated by hormones. Some boys at puberty, they have estrogen surge. And due to estrogen surge, they might develop a gynecomastia. This can explain the gynecomastia. See, but generally, it will remain dormant, rudimentary ductal system in boys. But in girls, due to female hormones, estrogen mainly, and the growth hormone, that is why stunted girl or those they have problem in their hormones, also their breast, it will be affected. Not only the estrogen. If they have problem in their growth hormone, it will also affect the development of the breast. And due to this hormone, a complex branching morphogenesis start to develop. At the beginning, the ductal system, it was just a simple ductogenesis, but or morphogenesis. Then after stimulation of this hormone, side branches, elongations, bifurcations start to develop. You see like this, and then the side branches ended with what? What are these? Alveologenesis or terminal duct lobular units. They start to develop terminal duct lobular units. So by the end of pubertal phase, the lady having what? She developed a terminal duct lobular units, and then start to growth every 2 to 5 years until adult life. And then we'll see later during pregnancy, lactation, and postmenopausal involutions. Is it clear? Okay, so at puberty, the breast maturations occur in girls, but no more breast development in boys unless there is hormonal imbalance. And from puberty onwards, the breast develop every 2 to 5 years until adult life, and the growth involve all tissue, the gland tissue and the stroma due to cyclic hormones. So the change during menstrual cycles, does it affect the breast, the mammography? Yes, it affects the breast and consequently affecting the mammogram. How come? Do you have an idea? What is the response of cyclic hormone on the breast? Definitely there is variation in size, texture of the breast, and subsequently on mammographic density. And mammography performance definitely is going to be affected according to the change in mammographic density, according to week of menstrual cycles. What is the difference between follicular and luteal phase? Which the optimum time to do mammogram?
Secretary phase.
Who's talking?
Fatima.
Huh?
Fatima.
Fatima. Let us take it like that, slowly. Secretory phase. What will happen during secretory phase, Fatima? Secretory after ovulation, yes? Secretory phase, it is after ovulation. At the just before ovulation, you have the surge of or the peak of the estrogen. So the estrogen at the maximum. And 1 week after, you have the maximum progesterone. So the estrogen and progesterone at their peak. And they are responsible for proliferation, gland proliferation, water retention. So you expect to have the breast enlarged, nodular, lumpy, tender due to growth lobule. And can be even in fibrocystic especially, they can be swollen and tender and painful and all these features. And then subsequently the mammogram, it will tend to be dense and definitely will decrease the sensitivity and cancer detection. So this is not, definitely is not the optimum size. From 2nd, 3rd, and 4th weeks are not the optimum the optimum time, I mean, to do the mammography. While during the follicular phase, then after menstruation, the breast regressing in size, in nodularity, return to usual size, to usually smoothening, less tender, less dense, and it will become more sensitive. So the first week is the optimum time for mammography, especially for screening of premenopausal women to have the higher benefit. Okay? This is the importance of physiology and how we could apply it in our practice. Here you can see this is a fibrocystic. Look for the mammography, how it is nodular and how it is dense. Can you see these cysts? If I ask you to show me these cysts in this dense mammography, definitely is difficult. What is this hint? This lady having?
Where?
Having
calcification.
No. This
axillary tail.
Axillary tail of Spence. Okay, so we discussed already the mammogenesis during perinatal development or perinatal period, and we discuss it during puberty. The remaining is pregnancy. So first trimester, second trimester, third trimester, look for the breast. Following progression in pregnancy, the breast is getting larger. So what will happen? Look here, this is at puberty, starting the complex morphogenesis and progress during adult life, but look at it at pregnancy and lactations. Look for this terminal duct lobular unit, how it gets, you see, numerous and larger.
Proliferation.
Proliferate, it get numerous and larger. Can you see it here? It is getting, this is non-lactating normal breast, and this is a lactating or pregnant lady. Look how it is getting larger and getting numerous. You see it here, how are numerous and larger. Okay, so during pregnancy and lactation, and due to pregnancy related hormones that stimulate the proliferations are strongest. The estrogen, progesterone, and prolactin, they have strongest effect in the ductal and lobuloalveolar development. So a lot of proliferations, numerous proliferations of the gland. When gland is proliferate, it will be in expense of the fat. The gland proliferate, the fat reduce. So the relations of the gland to the fat, it will become very high. The breast, it will become almost completely full of the gland, replaced by the gland with paucity of the fat. That is why the breast is getting what?
Denser.
Highly dense, because there is no fat. Okay, and it becomes firm and nodular and lumpy, and this definitely will increase the density and make it very challenging and difficult to pick up any small cancer and any malignancy during expected during pregnancy. It will be very challenging. And also definitely the mammography poses some radiation to the developing fetus, but if it is necessary, you can do it with appropriate precautions. And also the MRI is not appropriate in that during pregnancy. The most appropriate is ultrasound. And in the second trimester, the milk accumulate within the breast, and after during lactation, even these changes, it become more and more, and then after weaning, the breast, after hormonal withdrawal, then the breast, what? It will involute, it will regress, it will return back. If the lady using one breast more than the other, it will result in asymmetry. This is one of the causes of asymmetry. So if we look here, this breast is very dense. Can you see any findings in this breast? Definitely is difficult, but we could understand that this is most likely lactating breast. If we look here, can you see all these? You see milk-filled ducts,
Dilated ducts, yeah.
And these galactoceles. You see, can you see it here? It was very difficult to appreciate it. And can you see this small cancer in this extremely dense? It could be, yani, appreciate. Why? Because it is at, you see, at the periphery. But if it is within here, even if it is at the periphery, it will be appreciated with difficulty. It's not an easy, appreciable lesions. Here we can compare 3 ladies, okay, having mammography before pregnancy and during lactations. Before pregnancy, during lactations. Can you see the same breast? The change in the density? Look for the breast before getting pregnant and look during lactations. This is the same breast. You see how is the breast become too much dense, and sometimes you can just bump the milk before doing mammography. If necessary to do mammography during lactation, it might slightly reduce the breast density. Okay, so let us go to postmenopausal. As we mentioned here, you see, during pregnancy, lactations, and in adult life, these alveologenesis and the gland proliferate too much. So what will happen during postmenopausal? These changes occur due to ovarian hormones, estrogen and progesterone. In postmenopausal, this hormone withdrawal. So what is the response of withdrawal of this hormone? It will be the reverse. Yes?
reduction
So,
في
will be decrease in the glandular tissue. The glandular tissue will decrease. Before we said during pregnancy, when the gland proliferate, it will be in expense of fat.
fat
The fat decrease. Now the gland decrease and the fat
opposite
will
increase.
increase. And the fibrous septa, you see, will appear. Sometimes we've seen the mammography, a lot of linear densities in a fatty breast. This is due to fibrosis, okay, of these septations, and due to incomplete involutions, also cyst might getting to appear in the mammography. And then the mammography appear fatty and easy to assess.
Detect.
Okay, if the patient receive in postmenopausal receive hormonal replacement therapy, what will happen? If she
proliferation.
huh?
Proliferation of glandular tissue.
Yes, it will reverse. The effect of hormone is the same. Again, she start to develop some fibroglandular tissue, and the mammography start to get dense, you see, and it might also become tender. Okay, here we can see a 34-year-old lady having a lot of fibroglandular parenchyma and subsequent dense breast. Compare it to this postmenopausal 73-year-old woman with almost completely fatty breast, and this coarse linear density is due to fibrotic bands, you see, and this remodeling process causes the glandular tissue to be replaced by fat, is, as you know, is influenced by the ovarian hormones, either progression or regression of these hormone. And definitely this will account for differences in size, shape, and architecture of the breast tissue. And here you can see the sensitivity of the fatty breast. Look for this tiny cancer, how it could be appreciated in this fatty breast. And this is an example for the same lady, her extremely dense breast when she was 30-year-old premenopausal. When she's getting menopause at 55-year-old, it becomes heterogeneously dense. There are more fat, but it's still heterogeneously dense because the glandular tissue, it was too much in the premenopausal age. And here, this is an example. What you can see here, in the image in between, you can see asymmetry was not seen at the baseline image. This lady received hormonal replacement therapy. Okay, and this is the baseline, and here slightly become denser, and there is asymmetry here. And this only 2 weeks after cessation of hormonal replacement therapy. Can you see the asymmetry, how it regrets? So definitely this asymmetry is not a malignancy, and it is just due to hormonal replacement therapy. And the message here, what we can learn, if the patient on hormonal replacement therapy and you have seen any abnormality on mammography, you have to stop it and repeat mammography to check if it is just related to the hormones or it is a real pathology before going for interventions. And this is again a lady on hormonal replacement therapy. Can you see the baseline before starting treatment? And look for the mammography, how it's getting denser and nodular. And there are multifocal, okay, focal densities or asymmetries. You see, asymmetries, yes, are multifocal asymmetries. You see, they found this multifocal asymmetry representing cyst on ultrasound. So it's important to look which one is a baseline and going to which directions. Okay, this lady having a breast cancer and she received tamoxifen therapy. Which one is the baseline and which one is the second one? What do you expect?
The denser is the second.
The denser is the second. Okay, why? Who said the denser is the second?
Sarah.
Why, Sarah? Why is the denser is second? What is the effect of tamoxifen?
Antagonize the estrogen.
Antagonize.
Yes, the age of the patient.
So,
Second is a,
So the denser is the first.
so it should be like this. This is a baseline, and this is the second. This is 4 years after starting tamoxifen. Like, what is the clinical significance of that? What is the clinical significance? As a radiologist, for us, we have to tell the clinicians, you see, we have to comment on that. And it is important. It has a significance for the clinician to tell him about the breast density after starting tamoxifen therapy. Why?
Good
Why?
response. Good response to treatment.
Excellent, well done. Who said good response?
Fatima.
Fatima, excellent, Fatima. Yes, yes. When reduction in mammographic breast density observed, it is associated with 65% lower risk of cancer recurrence. You see, it is a good prognostic factors. When you have seen, when they compare with those does not or do not show, those do not show reduction in breast density, they found that they decrease the risk of recurrence by 65%. So it has a clinical significance, and as a breast imager, you have to comment on it. You got the message? Now, we appreciate the importance of embryology and physiology. No comment? Is it important?
Yes, it is important. Yes, it is important.
Really important, yes. Huh? What is going on here? Mm-hmm. What is going on?
The one in the right side is abnormal.
On what base?
The tissue, the glandular tissue, only in the areolar nipple area.
Here?
The other.
Who's talking?
That's Fatma.
Fatma. Yes,
Mm.
but generally speaking, if you divide this, this
This is
side,
more asymmetrical
it
size.
should be mirror image. Yes, you said what?
Asymmetrical size.
Excellent, well done. The observation, there is asymmetry in the size. There is asymmetry in the size, one thing. And the glandular tissue is also small, very smaller on the left breast compared to the right. This is the right breast and this is the left breast. So the left breast is the left breast looks smaller with small glandular tissue. Any associated suspicious feature, this is an important thing. Any abnormality, any masses, any distortion, any asymmetry, any calcification, any skin skinning. Can you see any associated abnormal findings apart from this asymmetry?
No.
No. Excellent. Yes, this is the important thing. Since there is nothing, you see, it can be just developmental asymmetry, which is more common. You see, this case, it was virtually always developmental if there is nothing associated, the asymmetry. And during pubertal, you see, the lady, as we mentioned, the tenor, when the breast bud started to develop, it is commonly is asymmetric. One side is larger than the other. And usually the mother coming seeking medical advice because one side is swollen while the other is not. That is why she brought her daughter to seek medical advice. And then when the other start to develop, also it persists for a while, asymmetric. One side is larger than the other. But when they are getting old, okay, during adult life, then it will regress and become more or less symmetric. But it can persist with a little asymmetry, slight asymmetry between the two sides. Slight asymmetry is acceptable, but remarkable asymmetry, we have to search for the cause. And if the patient gaining weight and she has slight asymmetry, it might result in a more obvious discrepancy between the two breasts. This is another case. What is going on?
Asymmetry size also.
Asymmetry,
with focal lesion at the right breast upper outer.
Why is it there is focal lesion? You can say there is asymmetry.
Okay.
The descriptor is either mass asymmetry, architectural distortion, or calcifications. You see? So this side, okay, is smaller than the left, but there is asymmetry here. And this by ultrasound was a normal breast parenchyma.
Wow.
Do you have any observation that this side might be يعني aggravated by something to be smaller compared to the other side, the discrepancy might be much less than this, but there is something make it a little يعني more aggravated discrepancy in size. So here, regarding the quality, tell me, is it an optimum MLO both sides?
For me, the pectoralis major at right side is smaller, but it is a part of the asymmetry.
No, don't say it is a part. It's okay. No, it not only smaller. There is something else apart from smaller. We'll tell you, is it technical or is it related to that? Because if you look here, you see the apex.
It is the angles, yes,
at the same level.
Two breasts, yes, at the same level.
So,
but the right one is smaller in size than the left one.
One thing, but there is something more specific. Something more specific. What about the shape of the pectoralis? What do you expect the border of the pectoralis to be?
It's going to be a sharp, flat, no convexity.
No what? It should be
no convexity.
either straight or
sharp. Yeah.
Or convex.
If it's
or convex.
either straight or
no convexity.
but should not be
Concave.
It should not be concave. Here it
Yeah.
is concave.
Yeah.
This concavity indicate what? Indicate the muscle is
Atrophy.
contracted. The muscle is contracted. When the muscle is contracted, that means some of the breast is not included in the field of. This is regarding, this is might aggravate.
Yes.
Yeah, the smaller size of these breasts. You got it? But by ultrasound, there was nothing. And this lady just, she used one breast more than the other during lactations, okay? And it was related to the lactation asymmetry. Who is going to take this case?
In the previous one, no calcification and no auxiliary lymph nodes.
This one? Here?
Yeah, yes.
Nothing. It might be, if there is lymph nodes, it might be small. There is nothing. Yeah, the image is not an optimum one. Yeah. But it was normal. The cases was not, there was no pathology related to the case. The asymmetry in that case, it was just due to asymmetric using one breast for lactation more than the other one. When are regressing, one it will regress more than the other. That is it. And this is really common, really common. I have been faced by a lot of ladies in my practice coming with asymmetry and tell me during examination, they told me that they have this asymmetry and why. And when the first question I asked her, you are using this breast more than the other one? She's telling yes. I said that is the cause for the asymmetry, since there was no discrepancy. And usually she told you since long time, for years, it's like that. Then advise her to use the other one more, the smaller one, to use it more than that one, so she can compensate. Who is going to take this case?
One breast is smaller than the other with a global asymmetry of glandular tissue.
What do you think? What do you, yes, which one is abnormal? Or you think it is normal?
There is one small and there is no definitive focal lesion seen. No calcification, no skin thickening, no retraction.
This noise from which microphone? Yours, Sumaya?
Yes.
Why there is noise?
No one with me. I'm alone in my home.
No, it is not. It is not related to voice of somebody else. Just
يمكن
it is
السماعة بتتحرك.
as if it is movement, or, as if it is movement or something. Okay. Continue, Sumaya.
كده كويس.
Is better, yes. Continue. You said when, yani, this is vague, Sumaya. To tell me when one breast is smaller than the other or one breast is larger. Tell me exactly which breast is larger or which breast is smaller, and if it is related, yani, what do you think about this asymmetry? Is it significant? Is it not significant? Is it just associated with other findings? What is how you are going to manage the case? That is the way.
In the right breast is smaller than the left.
Yes,
the
you start correct. The right breast is smaller compared to the left one. Okay, excellent.
Glandular tissue also it is asymmetry. The right one have small glandules than the left. There is.
But generally, no. You see, yani it is related. خلاص, if you look for the gland in relation to the fat, more or less, look here, more or less the same. The whole breast is smaller on the right side, but relatively smaller the gland, accepted, no problem, accepted. But generally speaking, the whole breast is smaller. What else? Let us go. Is it just it is pathological asymmetry, or it is developmental asymmetry, or it is a benign asymmetry, or it is a malignant asymmetry?
Look, benign asymmetry.
Benign asymmetry. Right. On what base? On what base you said this is a benign asymmetry?
No associated suspicious abnormality.
Right.
No mass. There is a little microcalcification. No skin retraction. No skin thickening. No lymph nodes.
Type. This is your opinion. We accept it. Any other observer?
Retracted nipple.
There is an area of architectural distortion
where?
at the right upper quadrant of the right breast.
Excellent. Well done, Suhair. Well done. Where there is area of architectural distortion in the right outer breast. Where, yeah, Suhair? Excellent. Well done.
The right upper outer quadrant. Right. When
seen as what? Seen as what? Speculated lines or
no.
Or
a concavity of the glandular tissue at the upper part, posterior. Just here, it is a bit little retracted.
Excellent, excellent. The contour, the anterior, look for the anterior contour of the fat glandular interface. This is the contour of fat glandular interface. It has to be, you see, this is the contour. This is a contour. Look for the contour here. Look for this contour. It is disrupted. There is disruption. There is retraction. And where there is a contour is retraction, look, there is more dense compared to the remaining. Look for the remain here, this retraction. And look, there are lines here. And look here, if you compare, there is thickening. The areolar is thickening. And if you compare here, this area, you can see a little bit more vascularity, subtle, but it is there. And even look for the contour here and contour here, there is some distortions here. Subtle, yes, there are subtle. So what do you expect? What is next?
Ultrasound.
Ultrasound.
Ultrasound, yes. It was unremarkable, demonstrate non-mass-like parenchymal changes or parenchymal lesions. So
MRI.
biopsy before MRI, لكن dense breast.
yes. So this is an MRI. This is the MRI. What about the MRI? Confirm or again
left,
your findings?
on the left, I think it is
Right.
contrast subtraction with contrast.
Which one?
On the left side.
This one?
Mid.
Now
This
you
is mid.
change your mind, the abnormality on the left or on the right?
There is an area of
area of what, yes, where?
في area focus, I think focus of enhancement at the same
Where?
area at the right breast.
Yes. Now you have two images. You have mid and you have this coronal contrast image. Which one is abnormal? This one or this one?
Right.
The right side.
Yes, you
yes,
have large segmental clump enhancement, large area of clump segmental non-mass enhancement. And look for this breast, look for the vascularity, look for this, the vascularity here compared to the other side. And it is shrunken, okay? And this is abnormal enhanced. So the abnormal is?
Pathology, this is pathology. Cancer.
What do you expect to be the malignancy in this? And what is this sign? You know it, Suhair.
Lobular carcinoma.
Huh?
Lobular.
Excellent. Why lobular?
Non-mass like enhancement.
Yes. Why? What is this sign? Yeah, the affected breast, instead of getting
shrunken, first one is shrunken.
The shrunken breast sign. Yes, this shrinkage or shrunken breast sign associated with invasive lobular carcinoma can be rarely seen malinvasive ductal, but it is more common with invasive. So we have to be cautious when we evaluate asymmetry to make sure which size is abnormal. Huh? What about this case? Who is going to take this? This is photo. This is not a mammography.
Yeah.
What do you expect? What do you see? What you have seen?
The right is larger than the left.
The right is larger than the left, so there is asymmetry in size. In which image?
A.
In image A. So what happened in MHB? Dr. Muawiyah is not with us.
More or less the same size.
Dr. Muawiyah is not here. We miss him. This is Dr. Muawiyah Deborah.
Yes.
Yes, this is his job. So what happened here?
MHB, the left breast is larger than the right.
No, more or less the same. This is just an image. Yeah.
Reconstruction.
Yes, the reduction mammoplasty. They made reduction mammoplasty. So what do you think the cause of asymmetry? She's a young girl. This is young girl.
Developmental.
Same patient. This is 2 photos for same patient.
Yes, this is
after surgery.
After surgery.
After reduction. Oh.
Yes. So what do you think? She's a teenage.
She had gangantomastia. Gangantomastia.
Excellent. Well done, Nauras.
أيوة.
Yes, excellent. You pick it up. Yes. And this one. She has huge unilateral breast and she's 11-year-old.
This is most likely a breast tumor in this.
Yeah. So we have to exclude breast tumor, but there was no breast tumor. When ultrasound demonstrates excessive glandular tissue, excessive glandular parenchyma. That is
unilaterally.
Unilaterally. So
this could be the
Macromastia.
Macromastia. It is macromastia, but this engorgement of the veins due to rapid excessive breast. It can be unilateral. Rare, but it can be unilateral. And what about these? This is the same lady here.
Before surgery, after surgery.
Less than 20 years, all are less than 20. Look for her face here, part of her face. She's young.
Macromastia.
Same. These all are same. Having, it can be asymmetric, it can be bilateral, it can be unilateral. And why mammography has no role in these cases?
Due to the density of the breast being young.
Yeah, because
dense glandular breast
depend on the patient age. And even these are very huge for mammography.
for mama.
And usually ultrasound plays more important role than mammography in these cases. And what about this one? She's the same.
الثلاثة صور دي حقت نفس العيانة.
Yes. When you look for her face here, she is so and bilateral. Here, yes, same condition. It is the same condition. When it occurs at the pubertal age, it has a specific name. Any of you know this name? The same macromastia, mammomegaly, gigantomastia. But when or hypertrophy, but it has a specific name at this age group. Just few months back, sent to me one case for opinion. Ultrasound, she was just, I think, 12 or 13-year-old, and her breast like lactating ladies, active lactating ladies. I was too much surprised. And then I said, oh, it will be juvenile breast hypertrophy. and it has a specific name, this juvenile breast hypertrophy. They call it virginal breast hypertrophy. Same, macromastia, gigantomastia, adolescent or juvenile breast hypertrophy. All the same names, alternative names. And it is rapid, excessive, massive glandular. Those are mostly glandular, like pregnant and lactating ladies. I'll show the same case in ultrasound lectures, inshallah. The role usually is ultrasound. And what about this case? Also, she looks young. Look for her breast, left breast is not pendulous, but she has asymmetry. What do you think?
Unilateral macromastia.
We agreed that we have first to exclude.
Is she lactating?
No, she's not married. What is the differential diagnosis? Here, this breast is almost completely normal. If you look here, this is bilateral. If you go here, these both are abnormal. Yani, you will think here, Nora's, her thinking was excellent. She said this is tumor. Yes, she has to exclude tumor because the other breast is completely normal. But here, both sides, but asymmetric, we'll think about. But in this case, also, since it is one breast is completely normal, while the other is abnormal, we have to exclude other causes. We have to exclude other causes of breast enlargement, like what?
Mastitis.
Mastitis is okay.
Tumor also.
Yes, it can be fibroepithelial. It can be fibrocystic. Adenosis. It can be fibroepithelial, giant fibroadenoma, phylloides tumor, and it can be neoplastic. It can be neoplastic, though there is no features, obvious features. But if you look here, the skin is normal. And that was strange. She has breast angiosarcoma, which is relatively rare. Represent how much the sarcoma of the breast from breast malignancy? 1%. So, this case we have seen it, asymmetry, but both sides are abnormal. This is the virginal breast hypertrophy macromastia, and as we mentioned, it has a differential diagnosis. So, what is virginal breast hypertrophy? This is the alternative names, as we mentioned, and it is a rapid and massive enlargement of one or both breasts in very menarchal, you see, very menarch girls, either before or just after menarche or during menarche. Exact etiology unknown, but they think that there is abnormal response of the breast tissue to the normal female-related hormones, and they mentioned also regarding the macromastia might be what related to imbalance in hormone, like what? Prolactinemia. And the complication, you have seen the complications. You have seen ulcerations, you have seen venous engorgement, necrosis. It might get infected, get hemorrhage, even to the life-threatening. But the least complication, the heavy breast, can cause what? Neck pain and shoulder pain. And some authors, they believe that it's associated with increased risk for malignancy. And the diagnosis, it is generally straightforward, but differential diagnosis has to be excluded. And as you know, mammography has no much role, but ultrasound generally demonstrate glandular texture. Okay, and it is multidisciplinary conditions, including surgical, pediatric, endocrine, gynecology disciplines, and successful diagnosis and management require complex team approach, because there is social, also it can create a social problem and impact. Some they feel embarrassed by this huge breast and these things. And there are several proposed treatments, mainly is surgical reduction, but sometimes they are giving them tamoxifen to inhibit glandular proliferations, either after surgery. They might expect, again, because the surgery does not remove the whole breast, they are making reduction, and they might expect the same reason or the same cause, same etiology is there, and might proliferate again. That is why they are giving them tamoxifen to inhibit the effect of proliferation of the gland. And it might be associated with Wittmann syndrome and other similar entities of macromastia, as we mentioned before, pregnancy macromastia or hypertrophy related to the abnormal stimulations of the breast to the pregnancy related hormone result in hypertrophy. Okay, let us go for this image. Any volunteer? Comment on the nipple. That is it. I need comment on the nipple. What about the nipple?
It's not in place.
Yes.
Retracted.
Yes.
Surgery.
This nipple, yeah, the nipple, they are getting inward, both sides. When you have seen it both sides, what do you expect?
Surgery.
Surgery bilateral?
No.
You have seen any clue for surgery, any scar?
Physiological retraction.
What?
Physiological retraction.
What do you mean by physiological?
Sometimes there's inverted nipple normally.
Yeah, but developmental you mean?
Developmental, yes.
Developmental, yes, yes. Most likely when the nipple retracted bilateral or identical, it is a congenital or a developmental. And in these cases, what do you think the cause for the nipple retraction? The cause is obvious here. And it is this is the very common cause, or even the commonest cause in our
Nipple
practice.
retraction
Every day we have seen this.
There's a nipple retraction, there's a small asymmetry mass like with microcalcification.
What do you think?
Malignancy.
Your expectation is malignancy. Any other opinion? You expected malignant. Look more for this type of classification.
Diffuse calcification.
It is diffuse. It is sharp, dense. Some are a little bit long but sharp, homogeneous, so dense. Some are rounded. If you magnify some, you can see it, lucent center, and some, and diffuse. Which type of classification this?
Milk of calcium.
And
Benign.
what about this? What is this band density? Represent what?
Ductal.
Dilated ductectasia, dilated duct.
Ductectasia. So
Ductal.
So this what? This classification, this type of classification, we call it what?
This is benign classification.
Benign.
Secretory classification or
Milk of
what?
calcium. Milk of calcium.
This is not milk of calcium. It's not milk of calcium, but what we call this type of the breast having ductectasia, chronic ductectasia with subsequent nipple retraction and diffuse ductal calcification, benign ductal calcification, dot mastitis.
I see too.
Started by B. Plasma, yes. Plasma cell.
Plasma cell mastitis.
This is the plasma cell mastitis. This is the ductectasia is the commonest cause of nipple retraction. Is a benign and the commonest cause. So what about the nipple here? And what is the role of technologist? What do you think about this nipple? Are they normal? It's supposed to be like this?
No, the right nipple is inverted.
It is bilateral, same. Both are the same.
Just facing downwards, pendulous breast.
No, in MLO, it's supposed to be like this. You see, two thirds up and 1/3, it's like that. But is it normal to see the nipple like this? The nipple is supposed to projected inward or outward.
And profile المفروض تكون.
Yeah, now it is, this breast is in profile, but the nipple are projected
Inward.
Inverted, projected.
Outward. What does it mean?
Retracted.
Retraction associated with
These are retracted. Technologist has to comment on mammography sheets. They have to write for you. Both nipples are seen flattened or retracted or like this. Look, this is the same patient. The same patient. Is it clear now?
Yes.
Both sides slit-like. And this type, they call it retractions. When the whole nipple getting pulled inward, they call it inversion. But at the end, retraction, inversion, they are used interchangeably. It can be unilateral, bilateral, congenital, acquired, benign, or malignant. Okay, it depends upon the history. This is the normal nipple, which is what? What is the difference between this and this?
Outward.
Everted
or looking outward, and this looking
inward.
This is inward against flattened against the breast or inward directed. This is sticking outward or everted. This is different between the normal and abnormal. And when the nipple inversion or retraction is concerning, when it will be concerning.
If associated clinical manifestation, such as thickening of the skin, with the orange.
Okay, what else?
If
Before
it is
that.
unilateral.
If it is unilateral and
associated with skin thickening, abnormal
if it is
density.
happening clinically, clinically.
Mm.
If it is unilateral and rapid, يعني if it happened rapidly, occur rapidly, خلاص, unilateral, rapidly develop this retraction, when this inversion or retraction unilateral and rapidly develop within few months, then it will be alarming for malignancy. Otherwise, it can be, if it is long-standing or bilateral, most of the time is benign. It can be congenital since birth, and each in 2% it can be reducible. Yani you can get it out and in, okay? And mostly it will be the congenital, most of the time it will be bilateral, but in 13% congenital retraction can be unilateral. So still we have yani percentage of unilateral congenital nipple retraction. Otherwise, it can be related to aging, related to breastfeeding, surgery, infection, injury, whatever. So what is the cause of that retraction? Just let us go through the development of the nipple. You know, at the beginning we said, you see, when the ectodermal thickening developed, there was a depression at the coverage of these ducts called a mammary pit. You remember that? During antenatal life, this mammary pit, you see, ectodermal thickening, it is there at the coverage of the ducts. And underlying here, we said what? This is the mesenchyme, where the stroma developed. It means what? It contains fat. This down contains fat connective tissue containing smooth muscles. When these smooth muscles, fat and connective tissue develop, proliferate, you see, it leads to what? Pushing the nipple outward to get everted. You see, this is a surrounding here, mesenchyme surrounding the ducts, which is representing the stroma, develop, pushing the nipple to get everted. So when we look to the nipple to see, and this also by the end of neonatal life, it can occur just after birth, immediately after birth, but usually during antenatal, by the end of pregnancy, it gets everted. Okay, so what are the components of the nipple areolar complex? When we look here, it is an ectodermal. It is an ectodermal. It contains these ducts, which should open on it. Okay, contain a smooth muscle, connective tissue. Okay, and rich in lymphatics and vessels, but it devoid fats, and contain the skin, what? Sebaceous glands and Montgomery glands, ducts, nerves, lymphatics, Montgomery glands, numerous blood vessels, abundant lymphatics, and the lymphatics here, as you know, call it subareolar plexus or subs plexus, and may contain epidermally located mammary duct epithelia, but it devoid of fat. These why are important to underline, to understand what is the pathology expected to be seen in the nipple areolar complex according to the component of each. So originally the nipple is inverted and then get everted. So which one supposed to be first? This one. This one, you see, when it failed, when it is like this, congenitally, not getting everted, this is the original one. And this, you see, during the development, it gets everted. So expected in 2% to persist inverted. In 2% of women, expect the nipple, even unilateral or bilateral, to stay in its situation of inversion. And in 23%, the morphology might be flattened. Yani not completely everted. Just start to get everted, but it failed to completely evert and it become flattened. But the majority, 75%, the nipple morphology is normally everted. And in yani, especially if the baby is prenatal, premature baby, you expect the nipple to be inverted or not well developed. And sometimes even the infancy, they have poor form nipple, but the inverted nipple by the puberty expected to be fully developed like this and everted like this generally. But as we mentioned, in some percentage, it might stay as inverted or flattened. What is ethelia? What is ethelia?
Absence of the nipple.
Absent nipple, yes. We said in the beginning, we talk about polythelia, supernumerary nipples, but ethelia from the beginning failed to develop the nipple, which is rare conditions. Either, we said it developed from the ectoderm. If there is ectodermal dysplasia, it might be failed, okay? And if she has no, the lady has no nipple, she cannot breastfeed her baby, definitely. What is wrong in this case?
Large right nipple. Large right nipple.
Enlarged right nipple, excellent. Enlarged right nipple, excellent, well done. So, what is the cause of that?
Could be a normal variant. Could be a normal variant. It could be due to pathology like inflammation, Beget disease.
Okay, so you have to look carefully. You have to look in this case.
Is this patient specific?
Yes.
Specific for, specific.
Yes, you have to tell me this patient. Look for the history first, and then.
Yes.
So the patient chronic renal failure.
Renal failure.
Both breast.
Genital fistula.
Edematous breast. Bilateral edematous.
Demonstrate some edema, but nothing else. Nothing is there.
Retroareolar density also.
أيوة.
At the right breast.
Yes, في asymmetry here and asymmetry where? This is asymmetry when you compare the nipple asymmetric. Look for the skin. Compare the two sides of the skin. Compare.
Here, yeah.
Trabecular.
Look for the
trabecular thickening, bilateral. Bilateral trabecular
the edema expected due to chronic. But look for the fat glandular interfacial concavity posteriorly here. Look for the glandular fat interface here. What about this?
More.
What about this? Asymmetry.
This asymmetry also.
And you have asymmetry here. And you have some thickening associated. And if you look carefully within the nipple, you might see something. Can you see anything?
Soft tissue. Sorry.
Can you see the nipple here?
Yeah,
the nipple
hyperdense.
What about this hyperdense seen within the nipple? Hyperdense foci.
Calcification.
Calcification. And you can see calcification within the nipple. So, is it developmental? In a postmenopausal 64-year-old?
No, I'm just looking generally, talking generally at the ferris, but this is pathology.
Yeah.
This is suspicious pathology.
Suspicious.
Chronic renal
Could be inflammatory carcinoma. No, you have to put inflammatory carcinoma from the start.
Why you go for inflammatory carcinoma? Why you said inflammatory carcinoma, yeah, Suhair? Why not
bilateral? More at the right side.
No. No, why you said bilateral?
Bilateral edema, but more at the right side.
You have explanation for bilateral edema, chronic renal failure, on hemodialysis.
And asymmetry also. You have asymmetry, focal asymmetry at the right side.
Yeah, but why you go for yeah, you have two differential. Either you
could have infection.
Even you have cancer extending, infiltrating the nipple, or you have budget disease. Do you agree?
Yes, agree. Yes.
What are the structures when you analyze the nipple, put in your mind? You see, enlarged nipple, it can be benign or malignant. Any palpable mass, nipple areolar anatomy, you have to think about it. Look, the dimension generally is variable, but look for the texture. Compare it with the other side. Okay? Definitely here it is enlarged. You observe it. Remember the anatomy of the nipple. And definitely you are not good to put anything related to fat in the differential diagnosis. And this is the nipple. Look for the nipple. The calcification is there. Not only the calcification, it is enlarged, it is hypo, it is distorted. Look for these ducts and look far away. This area, it is here. You look for this lobulated asymmetry. This is a lobulated asymmetry within the breast. So the same texture of the mass, the same texture of that lesion in a case of budget disease. Okay? Extending through the duct into the nipple, and the same infiltrating the lesions. What about this case? Sarah could not join us. What about this case?
The breast was arrested.
Excellent, well done. You have seen it before, huh?
Yes.
Fatma.
Yes.
Yes, arrested, excellent. Why it is arrested?
So radiation or surgery in the childhood. Maybe patient or person underwent radiation or radiotherapy or surgery at childhood.
No. I will help you. This is developmental. It is arrested, yes. It is arrested. She's a young girl. Okay. Or a young baby.
I get it. It arrested at Tanner stage 4.
Excellent.
Okay.
Tanner 4.
Yes.
What does it mean? At Tanner 4, yes. Excellent. Well done. What do you call it?
know the name, the structure.
Anyone? Any of you remember this? At tenor 4, what will happen at tenor 4? How many mounts do you have?
What means tenor 4? Yani, what means we didn't.
Stage. You have
Stage.
in the development of the breast, we'll see it in ultrasound, inshallah. The tenor,
We didn't see it. We didn't.
Very weird ultrasound.
ما حدثنا معاكم المرة اللي فاتت.
There are five stages, tenor stages in the breast development. Okay? In stage 4, the breast start like that. In stage 4, there are 2 mounts. There is elevations of the nipple, which is call it as papilla, elevation of the papilla, and at the same time also the areola is elevated, causing another mount. There are 2 mounts, and this is at stage 4. Stage 5, it will remain only the papilla elevated. The areola, it has to be what? It has to be reduced. It has to be regressed back. It has to get to the amount of the areola. It has to go back. If it failed to go back, the breast tissue might herniate through nipple areolar complex. So instead of staying the gland, staying in a large area of the breast, it will stay in a small space at nipple areolar complex. And at this time, so it has small space. So the development of the breast parenchyma, it will be reduced, and they call it as this appearance, they call it as tuberous breast. This is a tuberous breast. You got it? A tuberous breast. And these are the tenor staging, stage 1, 2, 3, 4, and 5. And we said the thylarch is corresponding to tenor 2. And after that, then start to, the child has to have tenor 1. Then at thylarch, they will have tenor 2. And then to adult life, they will develop 3, 4, because we said from puberty to adult life, still there is development of the breast. So the breast, it will go through 3, 4, and 5. At 4 here there is elevation of the papilla, as well as there is elevation of the areola. Both are elevated. Look for the skin. There is elevation here or here. Both are elevated. Stage 5, then the elevations or the mount of the areola, it will go back. It will recede back. And look for the skin going straight. Then you have only elevation of the papilla. If it will fail to go back, then the breast might herniate here, and this, instead of placing in all this area, it will place only in this small area, and this will hinder it is development and progress, and just you will see it as small. This is a gland. This is a fibroglandular tissue only, are sitting here at the nipple areolar complex. This is a hernia. You got it? Congenital hernia of the breast. Is it clear? Sumaya?
Clear, yeah.
Okay. So we can conclude our lecture, and we agreed that understanding of the detailed breast embryology and physiology will help us to enhance our ability to interpret the image. And we study that, and we know the breast tissue developed from the milk line, which is band of ectodermal thickening, and at birth there is no difference between male and female breast. And this is also, it has a clinical significance when they are seeking medical advice, coming to ultrasound department, asking you, a clinician or the parents. And there are many normal variations in the embryologic development. The latest one is what? We call it what? Tuberous breast. And the ectopic breast is a rare condition, but it might pose diagnostic challenge that highlights the importance of radiology pathology correlation. And the pubertal growth is due to gland as well as fibro-fatty proliferation. Both are stimulated by hormones, and the proliferation of the stroma as well as the gland result in a proliferation and development of the tissue pubertal breast, Multiple hormonal stimulation significantly increase the volume of breast tissue during pregnancy, and at the last, the amount of fibroglandular tissue decreases with age after menopausal. And thank you very much.
Thank you for you.
Thank you.
دكتورة رباب.
Let me